Welcome back to the Ask the Doc segment with Dr. William Whaley and Dr. Ray Tidman, brought to you by the Georgia Cancer Specialist and Northside Hospital Cancer Institute. And
who are you exactly?
I'm Joanne DePlanke Ruckert, and I'm sitting in for Brian Pritchard today. For BKP is off today.
And you're another one that doesn't ever have a bad hair day, right? That's what he always says at the first of the program, that he doesn't know a bad hair day.
Oh, I have bad hair days. In fact, what's funny is I was getting ready to run out the door and realized that my hair was still wet. I had never done my hair.
All right.
So I did actually.
You going to ask me about my tie?
Oh, that's a beautiful tie.
It is. What does it say on the back? Rush Limbaugh, it says?
Yes, it does.
And this is, I got this on this morning
that is
because it's got a
beautiful.
purple flower on there. I know very little about flowers if they're not just daisies. But Jane's garden back there has a purple flower in it today for springtime in the mountains. So I put on a tie that had a flower on it. It looked like Jane's
okay.
flower. So I don't know what it is.
Kind of goes with my kind of pink top.
Anyway, so this springtime outfit's a little chilly in the mountains. So Ray and I both have shirts on, jackets on, because we're not having hot flashes. Not necessarily to mean anything about that.
Hey, don't talk about my hot flashes.
Now, you can go back and start up now.
Well, are you implying that I have hot flashes?
Jane does.
Oh. Well,
You're in the right age group for them, though.
Well, I did that hormone replacement therapy that kept them away, and I thought when I stopped it about 2 years ago, because I realized why was I still taking this, no one said that I would still get hot flashes now at this age. And so I do suffer from that, and since that fits in with where we're going.
Take the hormones again.
I should?
Yeah, go ahead.
Yeah.
It'll help your bones.
I was just going to say it has made a huge difference in my bone density. So anyway, I think we have two interesting.
You want to hear the questions?
Yes, we have two interesting questions this week. So Dr. Whaley, why don't we start?
Are we here for questions? Are we doing here some questions? Is that what we're supposed to do? Is questions?
That's what I asked the doc. I was
okay,
is
that's
all
what
about.
BKP tells you. Okay, all right.
No, I watched the show.
Okay, yeah, from the green room, yeah.
Yes, from the green room.
All right.
Yes.
Both of these questions are interesting. I'm going to tell you about the first question is another survivorship question. Survivorship meaning what is the long-term course of cancer? How do you follow it? What are you supposed to watch for? And how COVID messed up the normal sequence of cancer or any other healthcare monitoring. And the second question we're going to come to is one that's about anemia and iron, but it focuses on something that many people think is cancer when they first hear about it, for reasons that Jolene and I were talking about in the green room.
In the green room, right.
Okay, now, my wife is 70 years old. 25 years ago, so she was 45. She had early stage hormone positive cancer of the right breast, and after mastectomy, she had one breast off then, took tamoxifen for 10 years. 9 years ago, she had early stage hormone positive cancer of the other breast, and then had both removed, meaning the other one went away, I guess. She is on an aromatase inhibitor. Now, you remember we've talked about different hormonal therapies. That's the newest therapy. And she was getting an infusion to prevent osteoporosis. So she was getting appropriately followed by her PCP or her oncologist, was probably getting an infusion. That was one of the older drugs, but she was getting an infusion, probably Zometa or something, to keep her bones strong. And then in the fall of 2019, she was due to do a bone density, do her infusion, so that meant she'd had the first one in early 19, and our house was struck by lightning. Well, that's interesting. She got involved in fixing it. Well, I guess after the house got fixed up, COVID struck. So it looks to me like she's got a couple, 2 to 3 years, I guess, she's been out of care. She hibernated and did not want to take the shots and was successful in avoiding COVID. She came out 6 weeks ago, and when getting a colonoscopy, her colon was perforated. Well, that's interesting.
Wow. Has
nothing to do with her cancer. And while getting scanned for repair, a compression fracture of the lower back was seen on CT scan. Now, frequently, cancer, if it recurs, can occur in bones. It will be seen as a pain that is evaluated and seen, or it can be a compression fracture. So it could be lots of things. Her oncologist did more scans and said this was osteoporosis. He has started an IV drug, calcium and vitamin D. So I guess in that 3 years, she got off the calcium and D because she would have been on it when she was taking that other drug. She does not need a vertebroplasty, she is told. Now, we've talked about vertebroplasty. My worry is that they did not biopsy the bone. I think that's probably a fairly good concern. I mean, we usually talk about biopsying these compression fractures, and how do they know this is not cancer? Well, I'm going to come back in a minute and tell you why I think they know it's not cancer, but what I'm going to do more on is focus on the idea that this woman had thin bones, they compressed, and she's a 25-year cancer survivor. So we know that she has been hormonally insufficient due to the treatments that she's received for 25 years.
And she has in medicine what we sometimes call a pathological fracture. That is, she had a fracture without trauma.
Yeah.
There's no reason
she
why
didn't
that
fall on
bone
the
should have
ice.
broken.
Yeah.
And so the doctors immediately say, well, what is, is this metastatic cancer, or is this osteoporosis? Is this a bone disorder or another process that's going on? Because it's not trauma.
Right. So that's why they did this scans.
Right.
All right. So the first thing we're going to do is talk just a little bit about the fact that she had a second cancer, what was that, 12 or 13 years after the first one. Put up that first symptoms and signs of cancer relapse. There's nothing about this particular scenario that suggests a cancer relapse or a second malignancy. So if you look at this big old long chart, they talk about things that occur in and around the breast to show that you've got a recurrence, and that's lumps and bumps and stuff that happens to the skin and all such as that. She didn't have any of that. The development of bone pain, usually if you're going to have a pathologic fracture from cancer, you got discomfort that occurs with it. It does not occur silently. So this was an incidental finding of something that occurred before that was not associated, as best we could tell, with her slipping and falling in the kitchen or on ice. But at least it did not cause pain. Okay, you can pull that down, Lonnie. The second part of this issue is the long-term and late side effects of breast cancer treatment, or what we call survivorship. Put up the next one and we'll pull it down pretty quick. And you'll see this is 2 pages long, very lengthy, but it's divided into things that occur in and around a surgical site, things that can occur as the long-term complication of radiation, and we've talked about radiation, fibrosis, and cough, things that occur because of you taking systemic therapy. The chemo might have given you heart disease, some other ones may have made you deaf, some could have hurt your kidneys. But lastly, the lowest, when you get all the way down here to there are 28 of these things, the third from the bottom, just before you get to long-term cognitive therapy, is osteoporosis. Okay, pull that down, Lonnie. So osteoporosis is a long-term side effect of the treatment of malignancy, but particularly breast cancer, because in breast cancer you're trying to get the hormone, the estrogen hormones out of the mix and out of the patient. And it's just like in prostate cancer, our treatments get rid of testosterone first. So prostate cancer patients who've got recurrent disease, they begin to complain of fatigue and aching and all that sort of stuff. So Ray, you're gonna put up that next one. We're gonna have it for just a minute. First of all, we're gonna talk about what is osteoporosis, how do you get it, and then what do you do about it. So okay, what's osteoporosis? Show that next patient, next slide here. This is what we call a dowager hump. If you stand in the line at Walmart or anywhere else and watch women over 50, you're going to see them come through with that gradual development of that hump in the back. But what's a little more important, you look at that top line. I had a woman in the office yesterday that was in there for colorectal cancer, and I said to you, how much shorter were you when they measured you today? She's 58 years old than you were when you were in your 20s. And she said, well, I thought she made a mistake. I'm 2.5 inches shorter than I was. Well, folks, I'm 3 inches shorter than I was when I played football. This is not limited to just females.
This is, Bill, this is another area that's happened. We talked
Pull that
about
one down, Lonnie.
We talk about the history of medicine. This is another whole area of medicine that has developed during our careers.
Correct, yes.
Back from those pictures, a radiologist would say incidental osteoporosis seen on x-ray.
Yeah, or
There's nothing you could
gouge
do
or
about it.
hump.
Or a hump, or
Yeah.
people lost their height, but there's nothing you could do about it.
Right.
And I remember in the mid-90s, I was offered a study looking at the new Fosamax drug at the time, and I turned it down because the study used placebo as its control. Well, at that time, we knew that hormone replacement therapy was effective at protecting women's bones. And to me, it was unethical to say, well, we're going to study this drug against placebo, because then I would be offering patients something in the study that's less than acceptable in my professional opinion.
Right. But that would have been standard of care at the time
Standard
the
of care
drug
at the
was
time,
being
because people
invented.
were fighting about,
Yeah.
well, can you give estrogen replacement, and does it cause X, Y, and Z?
Right. And Fosamax was causing esophagitis
And all
yeah,
these other,
it had
and
lots
it
of
was,
stuff.
and it's a serious drug.
Yeah, right.
So,
It ain't a vitamin.
Right.
All right, so go to this next picture here. Because the thing about this is a CT scan. This was taken, but not for this patient, but since this is the low back, remember this is a perforated colon, so they're looking at that part of the body. That's a compression fracture that is old. You can tell it's old because it's sclerotic. Pull that down. So that's what they saw, was the compression fracture. And in that circumstance, no trauma, no pain, it is much less likely to be a malignant compression fracture.
most unlikely.
Most unlikely.
Can I ask a question?
Sure, of course, that's your job.
Well, how do they know, since it was old, that she didn't fall?
They
Oh,
don't.
she probably did.
I mean,
She probably did. And here's what's interesting. She could have sneezed. She could have sneezed and caused that. But here's what's interesting. They said no pain. I suspect this is a tough lady. I suspect she had.
Yeah, she had 20,
as a matter of
25
fact,
years of
I
cancer
know
treatment.
that she had pain, because you don't break a bone without pain. And she toughed it out. She lived with it, and she didn't complain.
Well, you
about
can
it.
get slow compression fractures that occur gradually that don't hurt.
Yeah, but
That's not the
I just think that further history taking, she would go
Yeah.
back. Yeah, 2 years ago, and it hurt for weeks.
Yeah. So I will to make this guy
Yeah.
feel a little bit better, because we're not going to go into everything. He did some more scans. Well, what he did was a PET scan, and the PET scan was normal everywhere in the body, and she didn't have any evidence of metastatic disease in any other location. The clinical situation worked, and this was osteoporotic. And the reason he said she did not need a vertebroplasty was she wasn't unstable, she wasn't in pain. So she's just going to be a little shorter than she was. So we're getting into, put up that next one, we're getting into Dr. Tidman's bailiwick now. This is talking about preventing osteoporosis. The good primary care doc, here, I'll just hand you that one. You got that up there. The good primary care doc is doing everything on that list. He's doing it a lot more on thin, lightly complected, fair-eyed women than on, because that's a poster child. Fair eyes, relatively thin. Then you add cigarette smoking to it. Then you add early menopause to it, which this woman had, and I think we were discussing earlier. You may have had. Okay, Ray, take the ball and run with it.
All right, so Lonnie, if you put up that graph that I did real quickly, I'm going to go into the technology behind DEXA scanning, because DEXA scanning came out in the late 90s. And I actually had one of the first machines in the county running up here. Let's let the big truck go by for a second.
Beer truck. Nope, food truck.
Food truck. So,
where's the beer truck?
so one of
He's
the
already
way
come
the way a bone density scan works, even though it's in the X-ray department and it uses X-ray technology, it is really just a numerical measurement. They are shooting X-rays through a section of the body, and they're looking at how much of the X-rays are absorbed in that area, and they get a measurement of it's kind of a density measurement of bone from that. They're looking at particularly this lumbar spine and the hip, and there are complications for that. there's interesting math in this. We're looking at an older population, and we're trying to figure out what is ill or what is dangerous. Well, how do you do that? Well, the only way that they could figure out to do it was, let's go back and look at a young population, see what the bone densities are in that population, and compare it to this population and say, what's the change? What's the difference? And so when you get a T-score, you're getting a relative comparison of your bone density now versus what it should have been when you were 20. Okay? And
Standard deviation. It's a math.
It's math and standard deviation. So that little thing, you can take it down, Lonnie, was just a set of curves over time of how that standard deviation shifts with each generation of a lady's life. So you have a question?
Well, I was just going to say that I was taking the hormone replacement therapy until December of 2019, all right? And
Quit for COVID?
No, it just happened, all right? I just read somewhere that it wasn't good to take it for that many
Oh my
years.
goodness, she was back on Dr. Google. She did
Yeah.
not discuss this with her primary care physician or her gynecologist.
I did discuss it with my gynecologist, who said, agreed that I should go off of it. However, my bone density, when I was having it every 5 years, the last one I had before I went off of it, the person doing it said that I had the bone density of a 35-year-old. All right.
Okay.
Whereas now, recently, I found out my bone density is much less. My primary care doctor has now put me on vitamin D and calcium, and you said earlier I should go back on the hormones.
Well, we don't want to practice medicine on the radio.
I understand, but I'm
but
going to ask.
That's a good point. And there's a lot of miscommunication and a lot of misunderstanding, even in our own profession. Okay.
And I have no history of breast cancer in my family, which was one of the
calcium and
reasons.
vitamin D won't do you any good unless you are stressing the bone. In other words, to make that calcium and vitamin D do something, you've got to stress the bone. So this weekend is going to be the finals of the French Open tennis tournament. So you're going to have a 40-something-year-old tennis playing woman playing an 18-year-old tennis playing woman from Atlanta. And if you x-ray the tennis racket holding arm of the older woman, it's going to have a denser bone than the opposite side. So that calcium and vitamin D will not go into that bone unless you're stressing it. And that's why you have to do some sort of resistance exercise. Now, I wasn't getting ready to go there, but if you imagine that woman in Africa or the Caribbean with that bucket, that basket on her head, and then that thing of water on top of it, walking around like that, that's the ideal exercise to prevent osteoporosis, because every bit of that stress goes through the skeleton. You with me?
Yes.
Now, if you take an adult woman whose shoulders are attached here and her arms are there, and she puts a can of pork and beans in each hand, or a 1 or 2 pound weight in each hand, and then does like these other women are doing out here and walks 45 minutes or an hour with that weight in her hand doing this, when she's walked 1 mile doing that with a 1 pound weight, she's lifted 3,000 pounds. When she has walked for an hour, she's lifted 5,000 or 6,000 pounds. With her arms attached there, that's going through all of the skeleton that is likely to develop osteoporosis and break. And that's what the primary care doc over there is going to do. The calcium and D won't do it.
They're needed, but they won't do it alone.
Won't do it alone. It's a three-legged stool. It's got to be with the exercise. Otherwise, you might as well get over it.
And that's why when you pull a male or female astronaut who's been up on the space station for a month, they can't stand up and they've lost bone mass. And that's despite the fact that they're doing resistance training up there.
Yeah, because it's not done against gravity.
Because they're not having enough loads, as Bill's applying it. But one other
they're doing that stuff on the bike, and that's good for their heart, but it ain't good for their bone and their muscle mass.
So here's the critical take-home message from this. We are able to measure this important aspect of health, which is how dense are your bones. You need to go make sure.
You got everything off of there, right?
You need to go and make sure that that's being done. You need to know your T-score, and you need to be engaged with a physician who is attending to that T-score.
And lastly, you were said every 5 years.
Much more
If you're
often.
over 50, It ain't. That's the wrong interval.
Yeah.
I'm going to say that the interval that insurance will pay for is 2.
Yeah.
And if insurance will pay for it at 2 years, that tells you that 2 years is the minimum interval. Okay, let's go to the next one here, because we're talking about somebody who's really got osteoporosis and a compression fracture. So the next one is, the doctor said he's going to put her on some medicine, right? So here you go again. Always, got it up there? Always consider safety issues whether deciding to take drugs, okay? Pull that down. So you mentioned...
It's a new novel concept, Bill.
Well, yeah, but you...
Risk-benefit ratios,
yes,
things like that. It's a novel.
It's a novel concept. So put this next one up. We're going to spend a little while on this one. This is the FDA-approved pharmacologic options for treatment of osteoporosis. This over here, we're talking about preventing osteoporosis. All right. Estrogen replacement or hormone therapy, and you're going to see a lot of this here in a minute as we go down here. Or it's parts of there are various parts of this risk-benefit ratio thing that have to be individually attended to. You got a family history of thrombophlebitis. You've had a pulmonary embolism. You got a family history of breast ovarian cancer. But lots of reasons why you wouldn't want to take the estrogens.
Right.
Now, just because your ovaries wear out at age 52, which is the average age of life, historically women were dead by that time, right? When Social Security started, women lived to 62, so they weren't menopausal very long. All right, FDA approved treatments. First one says anabolic agents that increase bone turnover, meaning they increase its absorption but its building, and that drug that's in that category is called Forteo. It's an injectable drug. It's a little bit harder to take than the pills. The pills pretty much are out of use now. The next whole class of anti-resorptive drugs are variable. There's a calcitonin that comes from salmon. There's a drug that's a estrogen receptor modulator called raloxifene. That's got some cancer prevention and treatment things to it. But the big, you can pull this next one down, we're going to talk about it in a minute. The next is bisphosphonates. You said back here she was getting an infusion. Mm-hmm. The first one of those drugs to hit the market was Aridia. That drug was used for high blood calcium that occurs in malignancy. When they started doing that, they noticed that the bones of people who got that drug got better. And I've used this analogy many times. In the Bible, it says if you spread your seed on barren soil, it won't grow. On fertile soil, you get a good crop. By the side of the road, it grows and gets choked out by the weeds, which implies a characteristic to soil that makes it better or lesser able to supply the growth of the weed. Well, we learned once we had this group of drugs that stimulated bone strength, that cancer didn't grow very well in there. So the next place that this hypercalcemia drugs, Omeda, went was in people who had breast cancer to try and prevent bone metastasis, or patients who had any cancer, breast, lung, prostate that was in bone, to try and reduce its ability to grow. Because if you make that bone stronger, that cancer is not going to grow as well. So now it takes another decade of that before they say, hey, wait a minute. If it's doing that so good, why don't we try to use it in women who have osteopenia and osteoporosis to strengthen their bones? So put up the next one. You got that? Is that the big needle? Yeah. All right. This drug, Prolia, is a drug that's approved for osteoporosis treatment. You with me? But if you look at what it is, it's called denosumab. That is Xgeva. Pull it down. So it's the same drug for two different purposes. Xgeva is given once a month to people who have cancer in their bones. Prolia, in exactly the same dose, different label, is given twice a year to people who have osteoporosis to increase their bone density. So you give it 12 times a year to somebody that's got cancer, twice a year to try and improve bone density. It's the same doggone drug. You got it?
Yes.
All right. So you've taken a drug and you've changed its name and you've changed its direction. So if you gave Xgeva to people who didn't have cancer and they went on Dr. Google They said, oh my God, this is for cancer. By changing the name when they go on Dr. Google, they say, oh, they're reassured. I hate Dr. Google. Remember that?
Yes.
Let me. Well, we got a lot of trucks this morning.
We do. All right, so let me get into one more thing about Prolia, and I'm going to turn it over to him. Okay, put this next one up here, because this is the, and here is the gas truck.
He's his second round here.
Yes.
He's looking for somebody.
Yeah. So here, you got it up there?
He knows
All right.
I'm going to talk about you need to get your propane now.
Yeah, you do. The prices are going up. So if you look at the bottom right-hand cartoon, which we're not going to do much time, spend much time to. But one thing I wanted to show here was that this drug costs about $10,000 a year. It reduces the hip fracture and back fracture risk by 68%. Pull that down. Now,
Now, is that the Prolia or the Forteo?
Prolia. So much of what we have talked about historically has been insurance won't cover it, and that insurance won't cover it when they think that the cost of covering the thing for the long term does not outweigh the cost of the disease over the long term. So if insurance is paying for Prolia twice a year for you with osteoporosis at $10,000, they must really believe that that is cost effective, because when you get a hip fracture and you go in the hospital and you got to have the hip replaced, or you get 2 hip fractures, you get a spine, you'll notice that the cause of death in people over the age of 70 is frequently the long-term effects of a fall that's generally a fracture.
Yes.
And so even though that's 10 grand a year, insurance companies think treating the severe osteoporosis is worth the money. There you go, Ray.
So, back to repeating what I said, know your bone density and know it over time. This is more of a longevity preaching here. We are living
survivorship.
Well, survivorship for cancer, but I'm talking about we are living longer as Americans and humans.
Survivorship of life.
And we are outliving our endocrine organs. Men and women are living beyond the point when they make normal testosterone and normal estrogen, and those critical hormones have benefit to our bones. So if we want to live long, stay out of nursing homes, and stay active, then we need to know these numbers, and we need to know that they're very treatable, very treatable. And I would add one other thing. This is a parenthetical remark dating back to the early understanding of cholesterol. When I first came out of residency, we called a certain elevated cholesterol normal. And we said, well, we need to get it under normal. Well, normal was killing men in their 60s.
Yeah, because that was average.
That was
I've
average.
always
Normal
said
was
average
average,
is not ideal.
Right. So the idea was we need to get to what is healthy, not what is normal. So when you see a T-score and they say, well, she's not osteoporotic yet, she doesn't have a -2.5. -2.5, you're breaking your bones and end up in a nursing home. Okay? So I don't wait for patients to get to a -2.5. That to me is not good medical thinking. If I want to see their T-score dropping and they start going into the minus range, I want them exercising, I want them doing all the healthy things Bill talked about, and if they're still going down and I'm measuring them yearly, then I'm going to treat them with a pharmaceutical agent, because these agents reverse bone loss.
And then he's going to weigh the hazard-benefit
Hazard-benefits
ratio of those
right.
drugs with that patient. All right. We got another question here that's going to be a lot quicker, but this question is really good.
Well, before you start the question, I just want to mention our sponsor.
Oh, good, please.
Okay, so our second question is going to come to us from also the Georgia Cancer Specialist and Northside Hospital Cancer Institute with Dr. Whaley.
All right, so this question is about fibroid tumors, and it was actually about anemia and how do you treat anemia. And remember, anemia is not a diagnosis, just like fever is not a diagnosis. If you got a fever, you got to find out why you got it. So if you're anemic, you got to figure out why you got it, get rid of why you got the anemia, and then treat it at the same time. My sister is 42 years old. Okay, this is a young woman and in good health. 7 years ago, so she was 35. She had severe fibroids and had to have blood transfusions for anemia and she had a myomectomy. We'll talk about that again in a minute. But what that really means is they took out the fibroids. So that was 7 years ago. Now she has just left the hospital for transfusion again with a hemoglobin of 5. Normal is 15.
Wow.
This patient could have died with a hemoglobin of 5.
It's hard to think of her even standing up.
She was markedly symptomatic, couldn't stand up, was short of breath, and was probably fainting. She's had a return of her fibroids and has had very heavy bleeding for 6 months. That's not a lot of bleeding, so she probably was iron deficient that whole time. Her hematologist is going to give her iron. He asked her if she ever wanted to parent. She has been on oral iron since her original diagnosis, so that means for 7 years she's been taking oral iron and got to a hemoglobin of 5. That's why we repeatedly say that oral iron really is not the way to treat severe iron deficiency. IV iron is. All right, since her original diagnosis 7 years ago, and this is obviously not kept up with her blood loss. She has never married and has no children, and her answer was no. Remember, the oncologist asked her, do you want a parent? His suggestion was perhaps a hysterectomy, but her GYN suggests myomectomy again. What is your advice? Well, my advice is every patient's different, and you have to take the person's wishes and so forth into account. So we're going to have to go back and ask your sister. But what I want to say about fibroids is so much of this is misunderstood because these are called fibroid tumors, and in common country language, tumors often mean cancer. Second, they are frequently associated with pain and bleeding from the uterus, and cancer's 7 danger signals, if you read the little form you've been seeing for 50 years, are bleeding and pain are a sign of cancer. So now you got somebody who says mama's got a tumor and she's bleeding and she's in pain, and everybody in the family thinks she's got some sort of cancer. And then they say, well, her lower abdomen's all pooched up and she's got hard masses in there, and that just sounds like cancer. She's bleeding, she's in pain, she's got tumors, and she's pushed out there. Well,
let me tell you something. This is a tough lady.
Yeah, she does not have cancer.
Yeah, she doesn't have cancer. She's got pain and discomfort, and she's living with a hemoglobin dropping all the way down to 5. This is a tough lady.
Transferred. She's a tough lady. Okay, so anyway, we're going to go into some things here that sometimes are. This is women's health. We could have had my partner up here to help you, but the first one, put it up there. We're going to have it up there briefly. These are questions to ask women to help quantify blood loss during your menstrual cycle. Well, PCP has to do that, or a GYN has to do that. The ophthalmologist isn't going to do that. And if a woman has been having menstrual cycles all of her life, where she's changing her pads or tampons every 2 hours and having clots that are bigger than an inch, and she thinks that's normal, she doesn't know she's got excessive urinary blood loss unless somebody takes the history and tells her. And women with normal menstrual cycles rarely have to change their feminine hygiene product overnight. So this is just a list of questions. You can pull that down now. List of questions that the primary care doc is going to be asking a normal woman when he's doing his normal history about the gynecologic blood loss. He'll generally ask, how often are your periods? Where they're going to be roughly... They're going to be roughly 28 to 30 days apart. He's going to ask how long they last. 4 days, 5 days. I mean, are they heavy, average, or light? Well, people don't know. So can you compare it to some of your friends? Well, a lot of women will say my periods are every 21 days in the last 10, and they think that's normal. So you got to talk to your primary care doc. Okay, show this next one. This is a cartoon of a normal uterus, and they got 3 little spots in there that are different size and in different degrees of involvement of the uterus. These are fibroid nodular tumors. Like you get, Pull that down now. Okay. If you got a guy who's ever ruptured his biceps lifting weights, or his quadriceps or his thigh muscle, when it heals and he's got a knot where it broke, if you just looked at that knot under the microscope, it looks like a fibroid tumor because it's just a bunch of muscle. Put this next one up, it'll stay there just a minute. There are 7 different classifications of a fibroid. So there's a lot more to it than just mama has fibroids. Pull that one down. This next one right here is, and we went through this earlier, we'll talk about it, but that's a hysterectomy specimen of a fibroid uterus. This thing should look like a pear. If you just imagine a pear, that's what it should look like. And that thing right there looks like a barbell or something. Pull that one down.
Looks gnarly.
It looks gnarly. All right, so we're going to stop here. This woman is bleeding because of her fibroids. We're going to put this next one up. You see this algorithm. I've shown this algorithm about every 6 weeks. Treatment of iron deficiency in non-pregnant adults. When you start at the top of that algorithm, I didn't know BKP wasn't going to be here, right, so I brought it for him. We don't have to have a survival curve. When you get to the bottom...
But I was ready to say, when you asked, do I know what that is, I was going to say a logarithm, because I know that's the answer every time you ask.
All right, good. Okay. Except a survival curve.
Okay.
All right, so basically, at the end of the day, when you go falling through this whole thing, pull it down, Lonnie. Unless it's very minor anemia, that has no substantive recurrent likelihood, oral iron just hardly ever keeps up. So IV iron is the right thing to do here. So the treatment is right. The question was, the GYN suggested a myomectomy again, and the hematologist asked about hysterectomy, did not say get a hysterectomy. So now you've got this 42-year-old woman who does not want to be a parent, and she's having to make a decision about myomectomy, which is actually probably a bigger procedure than a vaginal hysterectomy in that age group, particularly if they leave the ovaries. Vaginal hysterectomy, if they leave the ovaries, you'll get in at 7 in the morning, be operated on, and be in your car at 1 o'clock in the afternoon on your way home. Would be a permanent fix.
We know would end periods.
End the periods. And we know that the myomectomy she had at age 35 lasted 7 years. Well, she's 42, 7 more years, she's going to be 49. She's going to be right back in this same spot, except historically it would occur quicker. So 3 to 5 years she'll be back in this same spot, and may have to do this twice more before she gets to the average age of menopause in this country, which is 52. So she, in my opinion, is going to tell them, do the hysterectomy. It'll probably save me 2 more episodes going through this, but as Ray said, she's tough. So she will have to make that decision.
So let me emphasize that. We may recommend A, but her answer, her choice is the right answer.
Her choice is the right answer.
Whatever choice she makes.
That's exactly
right.
So my advice is take the IV iron and discuss these 2 procedures.
Right.
Don't not do something,
right,
because you're going to need iron clearly every 2 or 3 months with this degree of blood loss. If she's gotten to a hemoglobin of 5 and she's only been bleeding again for 6 months, so she did not have any iron stores when she started. You can bleed up to 7 times the normal overflow of blood. As long as you've got plenty of iron in your body, you aren't going to become anemic. So once you get to this spot, there's no iron in her muscle either, because myoglobin loses the iron before the hemoglobin does, as I've said before. So she's kind of weak when she stands up. She was fainting and falling out here when she got transfused. Ball's in your court, Ray. What do you tell her?
I think you nailed it. I mean, we as humans have our bodies, and we are normalized to them and what they do and how they respond to things, and that may not be healthy. So when you engage a third party, a trusted physician or healthcare provider, part of that is trying to figure out, well, is what I'm going through normal or healthy, or is there a different way of doing this? You don't necessarily have to go in there and say, well, I have a complaint or I have a problem and I want it fixed. Sometimes your question is what I'm going through normal, and is there a different way?
Is there a difference?
Well, I was 45 when I was in that exact boat, and I chose to have the hysterectomy because I already had children and didn't want any more.
Well, you made the right decision.
And it was the best decision I ever made. I wish I had done it several years sooner. I put up with the excessive bleeding and whatever and the severe pain
For a long
years.
time.
Yes.
So
And
I usually save my humor for the end of the program, but I do have.
We're not ready for you.
No,
Go through
but
this. Go
it's
ahead.
important right here because when you're a young physician in training, you frequently take care of populations that have different notions of speech and word use, and particularly medical words. And so I was confronted one time during actually this was during medical school, taking a history, and the lady said that she had fireballs of the Eucharist. And I had to look
Grady,
around.
they are called fireballs.
Yeah, well, I had to look around and think for quite a few seconds to realize that she was talking about fibroids of the uterus. But she had
I mean,
had.
you were in Minnesota.
No,
you wouldn't
this
have
was this was in Cleveland, Ohio. But
Cleveland.
she
You
said
would've-
she
if
had
you'd been in Grady, you'd have known.
she'd had surgery for fireballs of the Eucharist.
You'd have known about it if you were. If you were in Grady, that's what they call. Everybody knew they were called fireballs. All right. Now we're gonna get. Well, before I get into the news of the day, I'm gonna ask you this question: how many? Because the first page of the Atlanta newspaper today said COVID cases on the rise, and it had graphs of the COVID cases on the rise. How many deaths have occurred in Fannin County from COVID in the last week?
0.
How many have occurred in the last 3 weeks?
0.
Okay, so you're still at 161.
Yes.
Now, how many cases of COVID have occurred, have occurred in Fannin County in the last week?
At 1.
Well, it was 1 last week. It's
Okay.
0 this week.
0 this week. Okay.
Okay,
Well,
now.
it should be 1 because I know of it and it hasn't gotten in the books yet. But anyway, so your
I do
point.
too. I do too.
Your
But-
point.
But what I'm getting to is, right now, so few people are getting tested. They're just staying home. They know they got the Omicron. They're blowing their nose 2 or 3 days. 2 members of my family have done that in the last 10 days, the ones that live down in Atlanta. They said, look, I got the runny nose. I don't know whether this is the pollen or not. I got work from home anyway. I just won't go to the store, and I'll send the family, and I won't be around them. So people have developed this sort of self-monitoring technique, and they don't really feel necessity to go out and get a test. Now, Medicare or the federal government or somebody will send you test kits for free, and you can test yourself. But the point I'm making is that we're living with this disease now, and yes, there's still people dying from it, and yes, it's still an issue, and yes, they canceled 8% of Delta's flights over the holiday weekend because people called in and couldn't staff the airplanes or the mechanics or the flight attendants.
And they ran off a lot of their staff.
Well, one more thing. Many people say they called in on Friday because they wanted a 4-day weekend and said they had COVID.
Yeah.
But
So
anyway.
let me digress for a minute. And by the way, when I make an expert or professional statement, it's not necessarily the opinion of our sponsor.
You're correct.
Okay. A pandemic is a state of disease measured in death and hospitalizations. That's what a pandemic is. It is not case counts. It is not lab counts. It has been a total bastardization of the word pandemic to refer to case counts, which are just test counts, as a statement of burden to the society. We do not have a pandemic now. We do not have a massive turnout of sick people in the hospital or dying. You repeatedly every week talk about 0, 0, 0 in this county, in this area. There is no pandemic going on now. The disease is endemic, and it will be endemic. It'll be around the world for years. So
We got some more bird flu came in this week.
Yeah, this week. And so those people in the news that are still doing what I call fear porn need to stop it. This thing's over and done with, and we need to move on with our life.
Because that gets them readership and watchership.
And eyeballs.
Okay, now we're going to let our host look at the first 6. I'm going to run through you. Don't put your glasses on. I'll do it for you. I'm going to read you the headlines of the first 6 things in the news today. It begins with food, just what the doctor ordered. Physicians are going to be prescribing food for people to help them. Now, don't get me into this, what's that stuff everybody does for gluten-free and all that baloney. All right. Second one, ancient concepts make new, timeline of food as medicine. Third, now this is another thing I don't want to hear, but how climate change is affecting our food. Next, in the future, you will get food by prescription. Next, looking back to food, milestones in food technology. Next one, how the food we eat helps drive climate change.
Oh my goodness.
Food, what's coming is better than sliced bread. Next, in the future, how will we feed ourselves? Next, personalized dieting as disease prevention. Next, presumed case of monkeypox in Los Angeles. So that's the first non-food item in the news, and the next one was the one I discussed earlier, is food allergy patients have a lower COVID risk than normal by at least 50 or 60%, and that does not apply to asthma, eczema, or other allergies. And as we were discussing, it does that probably because it reduces the ACE2 receptor, that type of inflammation in the nose and chest, and therefore that virus can't click in there and give you the virus. But you'd rather not have a food allergy, because if you've got a food allergy, it messes up how you can eat. So there.
Two things with that, Bill. So interestingly, children under 5 years of age do not have that ACE2 receptor, and therefore they're very rarely affected by COVID.
So somebody else trying to give. There's another one here.
Pushing COVID. They're trying to push the vaccine under 5 years of age for no reason.
Yeah, it makes sense.
And that is sad.
It is very sad.
It is.
But
right.
Okay, so one other thing about food: 70% of fertilizer comes from hydrocarbons. And so we have a war going on hydrocarbons, which is reducing the amount of fertilizer that's produced in the world.
You call about the wheat and stuff that's produced in the Ukraine?
All over the world. We fertilize and grow food. And in our lifetimes, world hunger has become really a non-issue because of fertilizer use and spread around the world. And now we are beating down the sources of fertilizer. So we're going to create a hunger problem and a food problem real soon.
Yeah, but back in Somalia and Mali and those places in Africa that have these huge famines that are going on now are because of corruption in the government.
Yeah.
And
maldistribution.
And also because of the inability to get clean water or a proper amount of water to put it into the ground, and again, that's political.
Yeah.
So that's politics messing up food. All right. Well, anyway, I got to get to work.
One other political thing.
Are we having an expert panel?
Yes.
Where are they in the green room?
Yes,
they're locked up. We're going to unhandcuff them. Just in the news, there's a book that is coming out came out this week called "The Body of Others" by Naomi Wolf, classic liberal, and I'm a classic conservative recommending this book. Check it out, The Body of Others.
What's it about?
It's about some misdeeds done in the pharmaceutical industry.
Oh, well, she'll have a big readership.
She will have it's already a bestseller. But
and I want to thank
Naomi Wolf,
Georgia cancer specialists affiliated with the Northside Comprehensive Cancer Center for the support of this hour and the springtime in the mountains. And this is a great weekend to come. I was looking at the weather. It isn't going to be terribly hot, and it's not likely to rain.
Awesome. That's awesome. Well, I want to thank Dr. Whaley and Dr. Tidman for joining us on this segment of Ask the Doc. And Lonnie, if you'll take us to commercial, we'll be back with the All-Star panel.